morning, everybody. I was wanted to share this panel. And I have to say that it was asked this a few minutes ago, so I don't have a chance to introduce all of the panel. So I will have to ask each member to present themselves. My name is Abdurrahman Bashir. I am the Executive Director of the Center of Excellence in eHealth in Saudi Arabia. Center of Excellence is part of the eHealth program.
My name is Hans-Jörg Loser. I am President of IHE Switzerland, and in my profession I work for the Cantonal Ministry of Public Health in the Canton of St. Gallen.
My name is Hubert Eisel. I'm Managing Director of Helga. This is the company responsible for the nationwide rollout of the electronic health record in Austria. Besides that, I'm co-chair of IHE Austria. The chair, since he is Jürgen Brandstedt from the Länder side, I'm from the user side.
Hello everybody, my name is Jari Porasmaa. I come from the Ministry of Social Affairs and Health in Finland, and I'm responsible there in the Ministry about architecture issues in healthcare and social care. And, one architectural issue is this interoperability piece, which I'm doing quite a lot of.
Okay, we have to run this session, and we have about 90 minutes to run this session. So we will use the same strategy as used in the previous one. I'm going to give each speaker about 4 minutes to present their country perspective, and then we will come back to you to produce a question to the floor. We will try to manage the comments to each question within 10 minutes, so we can have as much questions as we have, and to be as productive as we can. So, okay, thank you. I will start by talking about what is happening in Saudi Arabia with regard to interoperability. We have a 10-year strategy produced back in 2010, and includes 5 strategic objectives and a total of 85 programs. Out of these 5, 2 address issues that are very related to this work here. One is the strategic objective related to the care of patients. That is all the point of care applications like HIS, tax, RIS, LIS, and others. The other one is the one about connecting and measuring, which plans for the implementation of all the interoperability standards and connecting the different entities and facilities providing healthcare. In 2012, the Saudi IHE was formed, and this is how it's going to be governed. We actually have the IHE, or the Saudi Development Standard Development Organization, represented by every player in the Saudi healthcare market. And we mainly have the Ministry of Health providing about 60% of the healthcare service in Saudi Arabia. We have representation from the semi-government and other government entities, such as military departments that has its own healthcare facility, and they provide about 15 to 20% of the healthcare service in the market, as well as the private sector that provides about 20% of the healthcare in the market. Private sector is fully regulated by the Ministry of Health. So the Ministry of Health controls about 75% of healthcare in the market. So from this perspective, it's a bit convenient for the Ministry of Health to be the entity responsible for making sure that everybody in Saudi Arabia is connected and we have interoperable system. The Saudi Development Organizations has 4 committees. One is for business architecture, other for the policies and regulations, then the technical standards and the coding standards. The players in these committees come from the domain work groups, such as medication, lab, imaging, and as well as the technical issues such as security and so on. Can we go to the next one? By the end of this year, we should have about 7 complete use cases. Patient ID management, provider organization registry, coded lab results, lab orders, imaging, image sharing, and teleradiology and coding dispensation. After this, we will start with the rest of the use cases for that purpose.
This was React. I opened it again. PowerPoint has stopped.
Basically, the slide that will be displayed in a few moments talks about the criteria for what criteria do we use for use case development. The first criteria is that the use case has to be aligned with the strategy. So it has to be on our roadmap, so it will be included in the use cases that we work on. It has to fit the EHR requirements, so it has to be structured, high important, complete. It has to match patient needs as well as provider considerations, so it has to be useful and easy for the provider to work with. KPIs have to be produced based on value and priority. Also, the complexity of the use case from the perspective of the number of stakeholders engaged, as well as the IHE profile it pertains to when its complexity, maturity, and whether there is a workflow included in the profile, as well as the complexity of IT structure needed to operate the use case. So this is a summary of the main points related to interoperability we are doing in Saudi Arabia. I will now give the floor to Mr. Nath.
Okay, what is going on in Switzerland? To understand the complexity that we have in Switzerland, you have to focus the world map, drill down to Europe, and you find in the midst of Europe there's a whole Switzerland. We are not a member of the European Union. And if you even drill down within Switzerland, you find that we not only have 27 member states, but we have 26 cantons. And every of these cantons has an own legal framework, own financial resources, and every of these 26 cantons is responsible for healthcare services. So it's a quite complex coordination task we have to fulfill. But what we have is one federal law concerning the healthcare insurance that is fulfilled by about 80 insurance companies, competing companies, out of which the Swiss people can choose from year to year in which company they are insured. And they can choose from about 360 hospitals. 8 million people, 360 hospitals, 80 insurance companies. Only one insurance law, 26 data protection, 26 health laws. So obviously there's a need for coordination of all these players, and Swiss people expect that health data can be shared between all these hospitals, among all these insurance companies. And so patients are the real driver in Switzerland concerning interoperability, as they are used to use a credit card or as they are used to roam services in cellular phones. In this environment, the federal government, together with these 26 cantons, has established an e-health strategy in 2007, so 6 years from now, envisioning that every Swiss resident should have an electronic health record by 2015. On the organizational level, we founded a coordination organization called eHealth Swiss. It is led by the Ministry of Public Health, or the Federal Ministry, together with 26 cantons. All relevant stakeholders are invited to work in the working groups, such as standards and architecture, or education, or legal affairs in these 26 cantons. But they are only invited and not paid for their work. On a political and legal level, we recognized that a simple coordination of these stakeholders cannot be enough. We need a national one law, and this law is now in progress for establishing an electronic healthcare record. This law will regulate not what happens within these communities of the 26 cantons, but between the communication between these legal entities. So I can summarize what is going on is in a federal system, in a totally decentralized architecture. Sharing data in Switzerland means linking existing sources in different legal environments, and we do not have centralized components. So because some regions or cantons, they don't want to wait until these central components are built, and other regions don't want to be forced by some central instances. So in our architecture, based on IHE, we allow and support different time frames in different regions or cantons respectively. We could call it, or if you look at the approach in Switzerland, it's not a top-down approach from the federal level, nor is it a bottom-up approach from hospitals. You could call it something coordination from the middle out, where all the stakeholders coming together and have a common approach. This approach doesn't make us faster, but it makes us stable. Stable because it is based on consensus, which makes the decision stronger and is accepted by the participant stakeholders.
Thank you. And now we hear the Australian president.
Thank you. Maybe in 3 minutes, first some figures to Austria. In Austria we've got about 8 million inhabitants, 280 hospitals, roughly 16,000 outpatient doctors, and about 2,000 pharmacies, about 900 nursing homes, some large care organizations. With the ELGA project, which was started in 2006 with first conceptual work, and especially with the Law Act, which we had some months ago, by the end of 2009. Now we have a clear roadmap when which organizations, which healthcare providers have to be connected to the ELGA infrastructure. That is, by the beginning of 2015, all public funded hospitals have to be connected. By July 2016, the outpatient doctors and pharmacies have to be connected. At the beginning of 2017, the private hospitals, and then some years later, 2022, the dentists. What is now the ELGA infrastructure? It consists of several central components. We have already a master patient index running using the relevant IHE profiles, PQ, PICS, WIF, and patient update notification. We have a healthcare provider index. An access management system is currently a public tender out. Then there will be a central protocol data warehouse for collecting the several data, ATNA, arbitrary authentication data, for two reasons: to provide this data when has who accessed which data of me via the portal to all citizens via portal, the last central component, and then a variety of, and we assume between 10 and 20 IHE XDS affinity domains where the data are stored. Especially the provinces will implement affinity domains. Some of them work already for years on the topic, some of them already run. For example, Lower Austria, Alexander Schamann is known by many of you. They started at a very early stage with implementing the IHE infrastructure for their hospitals. They are leading edge in this area. And now the challenge is to connect all the affinity domains with the central components using a central access management system, and at last also provide the data itself, the possibility to steer the access rights and the protocol data to all Austrian citizens. In Austria, the law says it is an opt-out system. This means every Austrian takes part in ELGA unless he declares an opt-out. Well, that's it. IHE was set already in 2007 by the Federal Health Commission. It's the top-level decision panel in Austria in health topics as the standard for exchanging data in the health sector. And many thanks again to Alexander Schamann, who at a very early stage in the strategic discussions for ELGA prepared this decision, and now since 2007, it's no discussion in Austria how to implement the national health record, two standards, especially IHE, plus major 7 CDA, meaning document architecture for the documents themselves, are common sense. So, but this is already the next question. Thanks.
Thank you very much. Now we will listen
Finland experience.
Okay, thank you. Briefly about the general situation in Finland. Finland has about 5 million people, maybe 5.5 or something like that, and about 20 hospital districts. Each has multiple hospitals and about 170 healthcare centers. So for a small country, it's quite many centers and very widely distributed the healthcare system. About 80% is public and 20% private. And in 2006 we make a big national strategy or decision to gather information from this distributed system. So we make a modest decision, let's build one big database for all information. And then, like other countries have told, there's a certain time limit in which the organizations need to join. And the legislatures chose 1st of April 2011. So that is the April Fool's Day. And of course, in that case, it didn't make reality. So the ministry had to change the legislation a little bit in that point. They added some phasing in, so not all of the information, but the most relevant information. And in this national legislation that we have 3 services: an electronic archive, which gathers all of the information from the healthcare units. So starting now, there will be narrative patient record, lab information, procedures, risks, and so on. Then we have a prescription center, and into the prescription center, all of the pharmacies can look up any prescription, and healthcare puts the prescriptions in there. And this prescription center is the first fully deployed part of the national architecture. So we have all of the healthcare and pharmacies using this prescription center, and there's about 1,000 systems connected to the prescription center, and about 100 million messages yearly going there. And then the third service that is available in this national architecture is the patient portal. So patient can go to the portal and look all of the prescriptions and all of the information in the national archive, and he or she can also do some things for herself using the portal, put in some consent information and so on. So that is how the national IT services are being built, and then we had this strategy for ICT in 1996, I think. So a long time ago, and now we are in the works of building a new strategy for 2015 up to 2025. And the national services currently are built mainly using HL7 version 3, and then all of the content is in HL7 CDA documents. So we have no IHE yet in our national architecture. But one component that we are adding now, since the phased approach has come in, is imaging. And in imaging we will start using IHE, and that is the roadmap for us to build our national architecture more towards IHE compliant solutions. And then that was sort of like a general overview of Finland, but then I have a few more details about specific questions on slides, so we can look at those a bit later.
Thank you very much. Okay, now we will start receiving questions from you, please. We will try to give about 15 minutes to each question. Now we will leave a few minutes at the end for the panel members to give their comments.
Hello, my name is Rainer Schindel. I am from the Austrian e-card project. It's an identification project. I'm asking you from Finland about your medication prescription project, did you use the e-pharmacy profile?
I guess that's e-pharmacies and IHE profile?
Yes.
No, we did not use that profile. When did that profile become available? We started in 2006 and we didn't look at it then.
I can answer your question because I'm the co-chair of the IHE Pharmacy domain. If you started in 2006, I can tell you there were no IHE Pharmacy domain in this year. We were founded in 2008 and published our first profiles in 2010.
So one of the things that I know from the Canadian healthcare system is that we spend about 80% of our money on the hospital sector, and we provide 80% of our care, primary care. One of the things that I noted is that everybody talked about how you connect your hospitals, and I'm curious to know how you bring in your primary care physicians.
So I can at least tell about the Finnish situation. So we have a broad approach. It's not only hospitals, but also healthcare centers and private sector and occupational health. So everybody is connected to the same system, and information is shared between all the parties. So it's not hospitals only.
In Austria, the primary care sector will be connected by the middle of 2016. What we are working on is, by the beginning, we have only a few documents in ELGA. Say, the discharge letter from the doctors and nursing, the lab reports and radiology reports, then later including pictures. What we are working on is defining, harmonizing next reports, currently the pathology reports, with patient summary, and this will lead to more and more content over the years in ELGA, and then more and more contribution of the primary sector as a document source. At the beginning, the general practitioner is a document consumer. This will change over the years.
The situation in Switzerland is that only every fifth of the general practitioner has an electronic documentation. So 4 out of 5 are always or still on paper. And from those general practitioners that use a medical record, they have the ability to use an IHE adapter. They have their software could, if they want, communicate with these registries via this adapter that is implemented as DLL. You can use a proprietary protocol, pick the parameters, and this adapter converts the IHE conformant HL7 messages to have a look at the MPI, at the registry, and give documents out of the hospital repositories. But just read, they don't contribute with their own data until now.
In Saudi Arabia, we have about 1,000 primary healthcare centers. However, most of the healthcare delivery happens in hospitals. We are planning to have 1,000 more. There is somewhat underutilization of our primary healthcare system because of distribution and the state of the facilities and their staffing levels. We are improving this. There are so many different plans or thoughts now for how to connect these, and it appears that we are going to cluster the different primary healthcare centers to hospitals in the relevant areas, and so we create small clusters, say one hospital with 5, 6, or 7 primary healthcare centers. And this is the way we are working this week.
May I make a comment on that myself? My personal opinion is that exactly in this topic, connecting the GPs to, for example, national health records, IHE can leverage its advantages most. Because of the fact that you usually have 10 times as much GPs than hospitals. So it's 10 times more the chance to save costs by implementing IHE interfaces. And especially, in the beginning, usually the GPs are readers, listeners, what is produced by others. But by time, they are very important to also become contributors, especially the GPs which make reports like radiology, laboratory, and all those.
Can I just follow that? I mean, the biggest burden of disease is chronic disease rate. The largest single burden of disease that every country is facing is chronic disease, with a few exceptions. There's some that are infectious disease is still the highest one, but largely it's chronic disease. And that is something that is managed. When you fail, you manage it at the hospital. That is something that when we succeed, we manage it in primary care. And I see that that is an opportunity for IHE to significantly strengthen the number of profiles that are focused on supporting primary care.
Maybe one small comment when you take the microphone to the next question. Exactly, we in Finland are very much focusing now to how to strengthen the primary care sector so we can manage these diseases, and even before persons go to primary care, it's also very important to focus on prevention areas, because you have already sort of lost the game when you have a chronic disease, and a lot of energy is going into efforts that we can do to prevent people from falling into diabetes and obesity and so on.
Interested in two issues. One is how important are you finding getting critical mass, so that critical mass can cover perhaps critical mass in content, different content document types, which was mentioned earlier about Australia going for 3 first. But also critical mass in terms of users, because there's particularly in a system which isn't mandatory and where uptake is voluntary. As a provider, if I'm looking up a new patient and they tell me they've been to hospital last week, and I go in to look at their discharge summary, I expect to see it there. And if I look 3 or 4 times for 3 or 4 patients and don't find anything, I will lose faith in this and not bother, because I will not waste my time. So the sense of how important is getting all the patients into the system, and for the document types you are talking about, having all of them there as soon as possible to get confidence in uptake of the system. Is that a key success factor, or do you have other strategies for supporting very gradual uptake?
Alexander Schander, I will continue by your question about critical mass. And I have a question to you from Saudi Arabia. You mentioned some use cases you have defined. You mentioned you have some key performance indicators for these use cases. In comparison of all before presenters, the common things are the differences, and mostly the differences in the starting point. Austria, we started with 3 different kinds of documents, because these kind of documents are already digitally available because of coverage of PAC system, because of coverage of hospital information systems. On the other hand, we heard some requirements from disease management programs, but I think it's a long way from offering 1 or 2 documents up to covering the whole disease management program. Maybe we can add some aspects with the XDW document for covering workflow processes. But I think it is a very, very long way to find single documents up to build up a complete treatment process in the healthcare environment. And therefore I'm asking you once again, what kind of key performance indicators did you define?
Tarek, do you have an idea about this?
What about the use cases, KPIs?
The question is about what kind of KPIs we are going to use as part of the use case document. Yes, is that correct? Yeah, because the document here is, what I just presented here is about how we are going to select these use cases. And what was said here is that in order to consider a use case a valid one, we should be able to connect KPIs to them. I have to say that I don't have so many details on this, but they would be, I think, more related to, for example, if we have a use case for prescription of medication, then these might be some dimensions related to quantitative measures such as length of time. However, I'm not sure, and I can forward your question to Dr. Balkhair, who is the designer of these criteria, and get you the answer as soon as possible.
I'm Sangeli from Korea. I will question Finland. Do you collect patient-related information and data and store it in one central location? I wonder if that doesn't cause any problems, because in Korea we are very sensitive for patients' data, so it's almost impossible to collect and save data in one central location. NGOs and all hospitals are very sensitive. How do you do that? No problems with that in your country?
Yes, well, I guess it's quite country dependent on what kind of culture each country has, and in some countries it would be unthinkable to have one database where all of this information is. But I think in Finland most of the patients trust the doctors, and they trust these national institutions to keep this information safe, and the access to the information is of course secured and only by patient consent. So currently patients are not that critical about having this one big database, but they are more critical about that the doctor should always have the information available, that I get the best treatment possible, and the information that has been collected is presented to the doctor in a useful fashion. And one small comment about these critical mass and how to do that so that the doctor doesn't look at the empty database and get frustrated. So in Finland, I think we tied pretty much this thing into deployment strategies. So we had a quite regional deployment because patient moves not all over the country so much, but most of the patients stay in this one region. So we tried to make it so that all the pharmacies in the region are ready, so you can go to any pharmacy, and then also the healthcare centers start up at the same time, so doctors also get the benefit from having the medication from the other healthcare centers available. And sort of like these measuring things, we are on a quite low level measuring the usage, and then the benefits and things like that. We will focus that in that area in the coming years.
Concerning the question about the one database, in Austria, the documents are divided into about 10 to 20 databases. IHE XDS domains. Only the medication data will be stored in one central database. This is the consensus which could be reached in Austria. concerning the number of documents, I'm thinking with you when you say a doctor looks into a system when he's going to find something. The low number of documents and the process how to come to the next document is to a high extent due to intensive discussions with the Chamber of Doctors, which when making the law act and defining the law act, it was a kind of blocking strategy. They wanted to get Helge later, as late as possible, due to several reasons. And this led to, let's start with fewer, clear, defined documents and a clear process how to come to the text. But for that documents, there is the obligation for every healthcare provider who writes, for example, a radiology report or a lab report.
May we have this as a last comment before we move to the second?
Okay. In Australia, we've actually gone both ways. Our national federal health minister announced we would have a single IHE domain, but we'd have multiple repositories, similar to Switzerland architecture. We also have a national patient identification system, which is used as at least to be repealed. However, when it was actually delivered, we found that there was actually only a single central repository. And whilst the documentation at a high level indicated you could have more than other repositories, there was a significant reluctance on behalf of the vendor who supplied the national repository to actually allow that to happen. So it's actually quite difficult to move to that multiple repository architecture, even though obviously the IHE structure allows us. What we have found is that central repository architecture is vulnerable. If the National Patient Index Service goes offline for any reason, which is run by a different agency, which is the one that runs the IHE. So if either of them go offline, the whole system stops working. And of course, being done, there's very little coordination between those two groups that run the different international infrastructure. So we found that you can never quite tell when the national repository is going to be available, the documents are going to be available, because it might be unavailable because the national system is unavailable, or because the national repository is having some downtime. And it means that there's a single point of failure, multiple single points of failure. Whereas if we have a distributed infrastructure, obviously that becomes not just a problem. The other issue that we haven't yet really dealt with, the very small number of documents in the repository, is it actually scalable? We have a population of 3.5 million. Can you in fact run a single IHE experience domain that is of that size, which is untested?
Next question about the level of awareness of HIE in each country. I would like to ask each to give us a few minutes on this. Can we start with Karen?
Sure, I have a slide about that, so put it up there. And also open my computer.
Okay.
Remember what I have there. So the level of awareness in Finland, I think it's not very high. So we have a limited number of people who know about IHE. Some hospitals are using the IHE profiles in their tenders, and there's a lot of sort of like general level of knowledge available, and I think that the technical people are ahead, and vendors are telling that yes, IHE very wonderful, and it will help to make your healthcare enterprise integrate better. But I think that is one of the problems in Finland. We would need more experts from the hospitals to focus on the use case level and figure out what kind of problems you solve with IHE. So we have been trying to raise awareness about IHE. We've done several reports in Finnish about what IHE is in 2007 and 2009 and 2012. So we've been doing some basic work, and we do not have. In the morning there was a list about the countries who have a national initiative, and Finland was one of them. But actually, we don't have a national initiative. So they were trying to be proactive and put us there. But we have a sort of like a special interest group within HL7 who is focused on IHE, and we are hoping to formalize the national initiative during this year, so we will have it up and running during next year. I think that getting this deployment activity running in Finland is quite crucial for us, because we are building the national architecture more towards IHE, and we want the hospitals also to be very much aware of what IHE can do for them, not only when they have to join the national services and utilize the information in there, but also within the hospital setting.
But the level of awareness in Austria is, in my perception, quite high. As a KPI, I would mention the number of participants in this case. Also due to the decision of the Federal Health Commission in 2007, it's no question IHE yes or no. IHE is a standard for data interchange. And users include the relevant IHE profiles required in public tenders as mandatory criteria, including the connected channel integration statements, which have to be proven in the tender. Still not IHE compliant under a variety of software at the operational level, at the point of care, respectively the point of sale in the pharmacies, say the hospital information systems, the information systems for private practices, for the outpatient doctors, for the pharmacies, and also for care institutions, for nursing homes. And also due to the time frame in which we have to implement ELGA, there will be the necessity to connect this huge variety of software systems via adapters to the level of an affinity. And the communication from across affinity domain and affinity domain with the central components is strictly IHE compliant. Still open, and I think this needs some more time, is the communication affinity domain with a huge variety of systems. But Mr. Herzl already mentioned this point. I think when basis infrastructure is running in Austria, the next implementation project will refer to existing services at the next level, and to a certain time it will tip over, and also the operational systems, especially in the hospitals, will use more and more the IHE services at this level. Currently, we are talking about affinity domain and afterwards.
The situation in Switzerland, I would rate the awareness of IHE in Switzerland quite high, but not high enough. You can look at the eHealth Swiss Coordination Organization. Almost all the people working in the work group in the standards and architecture are also member in IHE Switzerland. So it's a very small company, it's very a small country, few people, but these few peoples are influencing very much. So already the first recommendation from eHealth Swiss in 2009 mentioned the XDS and XPDQ profiles that cantons should establish their domains based on IHE profiles. After having organized a Connectathon in 2012, all relevant stakeholders now know about IHE in Switzerland, and so I'm persuaded that for a national deployment committee, it is a very good sign and a very good way to raise the awareness in a country if you host a Connectathon. Although, honestly, it's a real tough job to do it, but it was the first contribution, as I mentioned yesterday, from IHE Switzerland to host that event. The awareness is missing in one stakeholder especially, the general practitioners and the software vendors for general practitioners. We have not yet managed to train these software vendors to implement these profiles. And yeah, it's the next step we have to do, persuade the software vendors. It's an architectural decision that the national body has done. And if you are, as a vendor, not on that architecture, you probably lose in the market. And so the very small vendors are against that decision. And so they are not willing to work with us. They work probably against us. That's the situation.
In Saudi Arabia, we are working at two levels, the vendor level as well as the level of the providers of care. The awareness level is still not very high, but we have a very demanding society for an electronic medical record in general. The first official showcase or Connectathon will be held in the beginning of May, this month, 30th of April and the 1st of May, and vendors will be invited to see that we are serious about using interoperability standards in Saudi Arabia, and hopefully that will be also accompanied with the announcing of the IHE Saudi. So we will have more commitment from vendors to contribute to and participate in this. For the healthcare providers, we have about 20 regions in Saudi Arabia. There is one e-health coordinator in each region. We have done about 7 workshops that included about 70 sessions with the purpose of providing awareness to these e-health regional managers, as well as a selected group of professionals. And what we've done in these workshops is that we have begun to work in developing the policies, looking at what is already available in the country and how would that impact designing how would that impact the standards. We also are now conducting training workshops for decision makers. This is a workshop directed to about a target of 2,000 people. Part of this is on interoperability. We just have started this the last month. And we also targeted the healthcare professionals through workshops. Part of on e-health in general, and part of it is on interoperability with the aim of starting the formation of implementation groups within hospitals, as well as the flying teams that would move from one implementation site to another. We are targeting 2,500 people to form our implementation support groups as well as the implementation managers. The third group is the IT professionals. We are targeting 500 of them, so they will be based in hospitals to help with the implementation. All of these groups will be given specific education on interoperability based on the level of decision that they need to make with regard to this. So now I will ask for your comments on this question related to awareness issues, please.
Yes. Please come in. I think one of the issues we find in gaining awareness, I suspect it's common worldwide, is that our national programs, which is really what galvanises interest, may implement IHE, but they use it beneath the surface, and IHE doesn't tend to get credited. So, for example, in the Australian National Program, if you look at their documentation, IHE is barely mentioned anywhere, perhaps in some of the early standards documents when they were looking at options, but when it comes to promoting implementation. And I think part of that is that these organisations running national programs want to have control over the infrastructure, because sometimes governments want things done differently, they want to be able to change rapidly, and also many of those organisations perhaps are in fact trying to almost compete with IHE about creating their own implementation profiles. And so there are some tensions between the people that potentially would want to use it. So IHE doesn't tend to get a high profile, certainly in Australia, and I know in the US they have the same issue. The profiles are used but not recognised. So the question is that important? IHE is being used. Maybe we just continue to promote its use and eventually it will become known, or is it important that IHE is recognised up front so that when other people want to solve other problems, the IHE methods can be used? I sort of think I feel more strongly that IHE needs to be known because there are healthcare, interoperability and collaboration issues which would use IHE methods on which if we're not known about, people won't go look for us.
Well, the situation in Saudi is that the president of IHE Saudi is also the director of the e-health strategy and change management office. So he's the person responsible for the standard development. He's the person responsible for following all the implementation of all strategy projects, as well as he is the person responsible for engaging all the different professional and stakeholder groups, and that gives that situation, although he is quite busy with all of these roles, but that kind of gives him access to many different parts of the system and enable the IHE to be an effective one. The IHE is now sponsored by the Ministry of Health in Saudi Arabia, so that kind of also gives it power to move to difference.
That's great.
May I comment on this? I think that's exactly the factor which leads to its success. Although IHE was founded and initially operated or influenced much from the vendor side, I think now as many nation or regional-wide programs come up, this has a little bit changed in the direction that IHE has to try to do exactly what, for example, happened in Austria, or as I just heard also in Saudi Arabia, that the right IHE skilled people get in contact with some government people or decision makers or heads of nationwide projects. For the first reason, to teach them what IHE offers. I myself, for example, was in contact with the European Commission, not directly the Commission, but the project lead of a very, very important upcoming European project named eSense. And in the beginning, it was a bit of that they want to do their own thing. And we all from IHE thought, oh God, that is very dangerous because they want to roll out some proprietary specifications over whole Europe. So we started to try to approach them in a way. And somehow I myself managed to get in contact with the technical part of the project lead of this project. And my learning was, I had with her, let's say, 20 minutes talk. And in these 20 minutes, I learned that they thought that IHE is a kind of competitor or enemy or at least an unfriendly organization to them, a threat. And we also thought the same, they are a threat to us. So with 20 minutes talk, we could set up this misunderstanding and could agree to a meeting, half a day, about talking to her what IHE is doing. I mean, this project is especially interesting because it's not only cross-country healthcare, it's cross-country and cross-sector. It's healthcare, it's e-procurement, e-justice, and all these things. So that's the direction I was going. Europe tries to maintain one common infrastructure for all e-things. And we have learned in IHE that some of our profiles are quite neutral. For example, XDAS, cross-document sharing, is content neutral, and it's basically no big deal to share a radiology report or a justice document. It's the same. So we offered them to educate them in the IHE methodology because we now have 13 years experience and learned that this works, also in testing experience. And we offered them to help them to create, let's say, neutralized profiles themselves, serving for their needs, and also benefit from our pre-work, for example, for in the patient citizen index cross-referencing or exchanging document. So I think that is the new focus of IHE, or should be the new focus of IHE, to try to get in contact on this level.
What were the success for Saudi and Austria? What were the keys to your success in driving it as a standard and adoption in your respective countries?
Well, success factor was at a very early stage, years ago, a clear decision on the standard, IHE and IHE 78 and DICOM procedures, etc. And currently, the latest decision for us was the Law Act, giving us a clear condition, opt-out, etc., clear due dates, when has which healthcare provider to be connected. This is when, who, and how was defined years earlier.
Okay, I guess for Saudi Arabia, the key success factors are that the interoperability was an integral part of the e-health strategy. This is the first e-health strategy that we ever developed, and the development started in 2008, ended by, produced in 2010. And since then, interoperability was mentioned as a key objective or a key project in this. So this is one. Second thing I think is the structure of the healthcare system in Saudi Arabia. Ministry of Health has one player, controls most of the market, so that would make things much easier. And what we are now hoping for is for the regulations to come in and kind of set what the responsibility of the different stakeholders in the market to interoperability. The whole healthcare sector in the country is organized by one entity called the Council for Health Services. All the stakeholders, all the different players in the healthcare market in Saudi Arabia sit in that council, and that council there are subcommittees. Looking at different issues. This is another vehicle that we can use to enforce countrywide regulations. So the setup, the governance of the healthcare system is a great driver to interoperability, I guess, in Saudi Arabia.
One of the things we did in the last panel session was talk about what are the assets that IHE has, and I can say that some of the markets that we're working in, one of the ones that I'm very involved in, developing country markets, the absolute marketing message is that we have connected loans, because for those low resource settings, their opportunity to just write into an RFP or write into a donor granting document or whatever, that whoever is the supplier of this technology has to be compliant with this list of profiles, is just so ready and so easy an opportunity for them. That is a hugely important message for us. And the Kenyans have just in their national email strategy document listed IHE profiles for every EMR that's being really Kenyan. Namibians, Indonesians, Philippines, South Africa, all of these countries are looking for a ready mechanism at the national level to say interoperability is the key, and there's a mechanism that can be achieved. And if you look elsewhere in adopting other standards and stacks, how do you require that somebody is demonstrably able to be interoperable is an unanswered question. And if you're in a low resource setting, answering that question is a very tall hurdle. So I think that's a very key thing. A few people mentioned that the connected fund certification information is important. I had a chance to hear Eric Heflin talking about in Texas. They just wrote that into the RFP for Texas's IHE. It's not only important for the developing country setting, that's a very key marketing message for us.
Okay, that's the last conversation because we have to move to the...
You asked me about the success factor in Austria. There was no ordinary. And they proposed the standard in the year 2006 to 2007. There was no alternate. And on the other hand, we have connected nets. IHE promised to solve all these interoperability problems across organizations. It's content neutral, and additionally, we have improvement on the connector law. Because one of the success aspects in Austria was we picked up about 40 people in the year 2007. Flew with them to the connector in Berlin, showed them it works between different companies. And they thought, yes, it works, and we have the decision on the national level. So maybe you can pick up a lot of people in your country, come to the next connector now. We have the next one in Vienna, 2014, and we will show them it works very well.
The next question about the role of IHE, policy process and profiles within the national or regional healthcare infrastructure. Can we start with you?
Well, the role of IHE profiles in Switzerland is that the recommendation of EL Swiss are purely based on IT infrastructure profiles, but especially based on cross-enterprise and cross-domain profiles. As you can imagine, 26 cantons, probably 20 affinity domains, they have to be connected cross-community. So we focus on these cross-community profiles. Those 6 pilot projects that are running are purely based on these recommendations, and all these projects, these cantons, are member of IHE Swiss. So from policy to the processes, it's those who go, they are all together. In the special case of the canton St. Gallen, we only pay incentives if our hospitals are compliant to these recommendations. Naturally, they can decide not to tear the money out of the canton, but if they want, if they comply, they have some money additionally. On the national level, policy making, we intend to have a certification process that not certifies the projects, but the implementation, the correct implementation of a community being cross-community capable with other domains. And finally, until now, we have not yet met a second best alternative to IHE interoperability profiles. So that's the reason why we are basing on our recommendations based on IHE profiles. And if we are lucky to have this interoperability in 26 regions in Switzerland, I'm persuaded that this could be a good example also for how European Union member states are doing business and probably interoperability worldwide. So that's the reason why we support IHE.
Okay, thank you. Hubert?
Thank you. Well, in Austria, the IT infrastructure domain is also the most relevant one. We are currently building the basic infrastructure to be able to exchange the data via the XDS cross-document sharing profiles, cross-community access, cross-enterprise user assertion, and patient demographics. We are even communicating with master patient index, patient identifier, cross-referencing, etc. In the e-medication project, we strongly prefer to the pharmacy profile. We will not use the full functionality because it's not needed for the first version of e-medication in Austria. But in this project, we intensively work together with Jürgen, who writes, is one of the writers of that. Regarding the implementation guidelines for the documents themselves, the discharge letter strongly refers to the content template within the patient care coordination domain, and the lab report strongly refers to the XD, the lab profile within the lab domain. Not 100%, but to a strong extent. The differences were documented and reported to the development committees as an input for their next release cycle. So let's see which of the differences could be solved in the next release cycle. This is where IHE and CBA overlap. So we referred to the content templates and the other things, the clinical document architecture. So these are the areas where IHE is used.
Thank you.
Okay, the role of IHE in these issues in Finland, as I told already, is not so big earlier, but now it's getting more important to include IHE in policy issues. So I think the decision to build this national imaging solution based on IHE profiles is a good start. And then also we have a legislation about doing enterprise architecture for all of the hospitals and healthcare centers. And there are many bad cases about this enterprise architecture. I read that in the United States there was this federal architecture thing which didn't really put in the benefits, but maybe in Finland one thing that we could do under this law is the interoperability part, because the law has interoperability base. So there we could select IHE as one of the things that could be used to improve interoperability. And I think that maybe the global IHE organization could support these different national initiatives by gathering sort of like a package of how IHE is being used. So we could put that package into the other policy people and tell that IHE is a good thing to promote interoperability. So cases like Austria, if I understand correctly, that your national solution is totally based on IHE and XDS would be good selling points when we discuss this, how deeply we want to get involved into IHE. Then we have some maybe grassroots things about IHE, because this National Social Insurance Institute, Kela, is building this national service, and now they are using the IHE test tools, the Gazelle tools, in this national interoperability testing, which is done on a connectathon and a projectathon level, and we are using sort of like the open source tools to build things on top of that. So we are doing sort of like practical things also, and in addition to the national parts, several regional projects have been started. So at least in the regional level, the hospitals are moving more towards IHE. But I think these other global organizations could support these national initiatives is one point that maybe the audience can give us pointers what's available now, and how do you feel about doing a thing like that.
Okay, I guess I answered this question already, but the IHE Saudi wants to contribute to the decision making with regard to the choice of infrastructure, the EHAP program. So that kind of, makes it, that's quite convenient. Of course, that does not, go for the other sectors, which are not managed directly by the infrastructure. So in the short time we have, we'll try about 10 minutes. We'll try to get your comments on this question before we go to the lunch break.
Yes, I need the microphone because got a cold in Istanbul. I will remember that. A question that I have for folks that are close to national program or ministries. Having heard the discussion, it seems to me that one thing we could do, especially thinking of Peter's comments, is very often, IHE is inside, but kind of buried 20 layers down into a project, and we need to recognize that, being in the business of interoperability, not being seen is success. Once you're visible, it means you stand in the way, and people will point their finger at you. So disappearing is good, but sometimes we need also to have some visibility. What would be the possibility of creating, we spoke of success stories, but I think a success story is maybe too ambitious. Maybe having a technical descriptor associated to a national project that may be in planning, that may be in the beginning of implementation, that may be in advanced implementation, simply exposing things. Because I'm getting that question over and over. Say, Charles, how much IHE is there in the USA? And honestly, to find this response is almost impossible. if you have to dig through the regulation of meaningful use and the reference and the reference and the reference, all of that, plus all of the exceptions, there are probably 20 people in the world who may know the answer to that question. So how could any other country know that? And it is a little bit the same for all of those national programs. It's you know, when you are on the outside, it's hard. So my question is, how politically correct would it be to make that factual description with an approval? Of course, you would need to review that. And I understand that a government doesn't want to say, I'm committed to IHE and only IHE, okay? You want to remain flexible in your choices and all of that. So without this being couched as a commitment forever and ever, at least some form of descriptor of what's inside a national project, would this be something that if IHE helps to do this and use this to be published on our website, would that be politically acceptable? Of course, if it is vetted by those national programs.
Yes. Okay.
Do I have a couple of maybes?
I already said yes, even though we are not, don't have so much IHE. We are planning and building, moving towards IHE, but I'd really like to hear from the other countries who are sort of like maybe more committed to IHE than Finland is. Having this sort of like a general description that Austria has selected IHE and we are using these profiles and so on. Having that available in some public place. I think that was something Charles was looking for.
The arguments used in 2007 for the decision of the Federal Health Commission is not published. But the key fact is, on a political level, it must be very simple, a very simple description. The situation in Austria is that most of the healthcare system is public funded with the Federal Health Commission, the provinces, the government itself, the Ministry of Health and the Social Security, which are the funders of the healthcare system, decide and make this decision. And at last, with simple presentation of the advantages, this decision could be made. So I don't have it now, but I think it's possible to give some key facts, not the exact text, which was in the commission, but some text that really would help if IHE Europe or international some slides on a political level, not too technical. So it's the benefit which can be realized with IHE in few words and few but very simple pictures. But that's it what we would have needed years ago, but we are lucky that we got this decision.
In case of Switzerland, I could imagine that, absolutely, because our recommendations are on the internet, unfortunately only in German and French, but we could translate some parts of it, why not? And we focus exactly on these cross-community aspects. We do not recommend how the communities should do it inside, but we focus on the communication between these communities, and whether these communities are very small or big or large, whether they are other cantons or the Principality of Liechtenstein or the Land Vorarlberg in Austria, it's always the same communication process outside and between these communities. I can imagine this.
I would be happy if IHE would provide a resource such as guidelines for the development of national bylaws, for example, supported by some good example guidelines from other countries. That would be helpful.
Thank you. I'd like to make a comment again about the branding issue. And I know we're going to have a panel dedicated to that, so I hope I'm not stealing any of the material. But at one level, it doesn't really matter whether it's called IHE or it's called some country's specification, as long as the job gets done, that is interoperability. But on another level, it does matter, and that's the level I'd like to talk about. One of the things we've always hoped for in IHE is that we can simplify the procurement process by asking for specific actors and specific profiles rather than 100 pages of specification. And if we don't call out IHE, we're back to the 100 pages of specification. So I think there's some value in terms of the efficiency side to call out IHE. It also makes it easier for the vendors to operate multinationally to say we use IHE in this jurisdiction and we also use IHE in this jurisdiction. So we, the vendor, don't have to reinvest again and again and again. So I think there is some value, and I'm convinced that calling out the brand of IHE is important. One of the things that we're learning from the pilot project and certification in the US is there's a lot of discussion now about different levels of certification. One at the IHE profile level, one, for example, at the ONC level, which is full of IHE. And when we get the two groups together, we're hearing now more and more some discussion about perhaps we can use certification for IHE as a prerequisite for entry into the certification program for ONC, where the IHE material is covered and the certification for that has some value, and then the certification that is required over top of IHE is only the incremental part. And I think there's more of that dialogue happening in the US, and I think we're going to see that in other jurisdictions as well. I think that's kind of an unexpected benefit of the certification programs that's going to call out the branding of IHE as being an integral part, because as we all know, there's IHE baked into so many places. And to allow that laddering, I'll call it laddering, or stepwise progression of certification is going to actually make that more relevant.
Two more last comments.
As a user on the hospital level, for ourselves, it was not so much the phrase of interoperability, which got us to IHE, because I think interoperability is only a phrase. What really is behind it is the costs for ourselves, because we want to reduce the costs in the same manner and keep the high level of quality. So interoperability is just one tool that should provide us with these two factors, costs and quality. And that's why we started to look at IHE and wanted to promote it, not really dependent on the national level, but we also promoted it on the national level because we can see that we can reduce our costs if we use this tool IHE as often as possible. That's our main goal nowadays, to promote it even on other applications. As I said in one of my first statements, we want to reuse it as often as possible to keep the costs of the whole things as low as possible. And the really big cost factors are infrastructure, it's knowledge. I think it's one of the main costs. Knowledge. We now are operating IT systems in Vienna for a long period, and we know that we have problems with older systems getting open knowledge over the years, still maintaining the services in a way that they are sure to use, sure for the patient. So that's the main point to use it, and I think that's why we on a regional level are promoting IHE Also, we have been in former times promoting our own standards because we are big enough to set standards for our own, but there were other big players who promoted their own standards. So in the end, we came to a lot of different standards using. And with IHE, we see the chance that we are agree on one common standard for everybody, and in this way, reducing costs, keeping quality levels high.
Is that the last comment?
Is that the last comment? I thought it's the legal comment, but he is close to 10.
Okay. Thank you very much for your contribution. We will have to go now to the lunch break. Which story is it set for?
I have some, just to close.
Okay, thank you.
Not the logistics. Okay. Thank you.